Okay. So today's session will be of shoulder joint. Okay, so today we are going to discuss shoulder joints. Okay, so before starting the topic, I would like to give the general information of the Unacademy platform. So I am the educator of Unacademy for the subject of anatomy and has got an experience of teaching of 7 years, and I have done my MD anatomy from Armed Force Medical College, Pune. So before starting the session, I would also like to give you the information about the plus subscription of Unacademy. Daily live sessions are going on the Unacademy platform. So you can take part in all kind of live sessions. Also, you can be a part of live test and quizzes, okay, which is every day it is going on the Unacademy platform. There is also for the person who has subscribed the Unacademy platform structures courses to clear their entrance exam, whether it is NEET PG, whether it is FMG or INICT. Unlimited access is there. You can see the videos live also, and if you have missed anything, you can also see it afterwards. You will have the PDF of all the notes, and if you wish to join the Unacademy platform, you can use my referral code Dr. Lisa -YT for 10% discount. So you can use my referral code for 10% discount. Now, I would also like to give you the information about the iconic subscription, which is the merging of the Prep Ladder and that of the Unacademy platform. So as we already know that Unacademy is a platform where the live classes and batches are going on, and you can also take part in live polls, and you can solve so many MCQs, and also you can attend the free live sessions of May of all 19 subject and difficult topics. By addition of Prep Ladder along with Unacademy, you can also access the video lectures and QBank 2 live tests and quizzes can be accessed. Rapid revision courses are always being available on the Unacademy platform. So if you wish to join the iconic subscription also, you can use my referral code Dr. Lisa -YT for 10% discount. Now, I would also like to give you information about the daily T20 which is going on for the aspirants who is going to appear for NEET PG 2022, and also for the aspirants who are going to appear for the NEET PG 2021. Okay, so this is daily T20 is the test series, and for the aspirants who are going to appear for NEET PG 2022, the timing is at 9 PM daily. Okay, it's absolutely free. And for the students and the aspirants who want to clear the examination of NEET PG 2021, daily live test series are absolutely free, taken at the timing of 8 PM. Okay, so now I would also like to give you the information about my free live classes. Actually, today is 30th November and today is the last day of the month. So today I am going to take 1 hour free live session on the Unacademy platform. And the timing is 7 PM. So, and the topic is the discussion of MCQs, which is of anatomy. So anatomy MCQs discussion for those who are going to appear for NEET PG 2021. Okay, so those who are going to appear for NEET PG 2021, and also the other students like the students of first year MBBS who are going to prepare for the next examination, and also FMG students, all students can be a part of this test series, which I am going to take of 60 minutes on 7 PM today itself. Okay, so if you wish, you can join my own group, that is so you can join my group, that is Monalisa Anatomy. My group is Monalisa Anatomy, and also I will share the Unacademy group, Telegram group, and here the links of all free sessions are provided. Okay, so here the link of free session will be provided. You can be a part of Unacademy NEET PG Telegram group or my own group, and you can ask your queries related to the anatomy subject. So now I should start with the topic of today's session, that is shoulder joint. So firstly, before starting the session, I would like to give a general brief of shoulder joint, that how I am going to cover the shoulder joint under how many topics or subheadings. So firstly, I am going to describe about the type of joint, then the articular surfaces of the joint, then the ligaments, then the relations, arterial supply, nerve supply, movements and clinical correlation. So under these subheadings, I am going to cover up the whole topic of shoulder joint. Okay. So firstly, let's start with the description of which type of joint is the shoulder joint. Okay. So first thing is that the shoulder joint is quite mobile joint in our body. It's the most mobile joint in our body. Shoulder joint is the most mobile joint in our body. It's a simple synovial ball and socket type of joint. It's a simple synovial ball and socket type of joint. And one more thing I just add on, that anything which we get is at the cost of something to be sacrificed. The same thing is with the shoulder joint, that it is most mobile, but there is chance of recurrent dislocations in so many cases. So stability is sacrificed to obtain greater degree of freedom. And I will also give the reason why, because the reason is the articular surfaces. So I will show you the articular surfaces and give you the reason why shoulder joint is a joint which is the most important joint which is going on for the, and it's often seen that recurrent dislocation has been seen in the case of shoulder joint. So at one line, simple synovial joint, ball and socket type of simple synovial joint. Now after that, coming to the articular surfaces. Okay, so let me describe the articular surfaces of shoulder joint. The articular, when I want to tell you about the articular surfaces of shoulder joint, the first thing is that the head of humerus is large and which is going to be articulated with a flat, or you can say not exactly flat but very shallow glenoid cavity. So yes, so the large head, so which is almost an rounded structure, or you can say a part of sphere, not a complete sphere, but it is 2/3 of a sphere. It is a rounded structure, and this head of the humerus has to be accumulated in a shallow glenoid cavity of the scapula. Now, for the proper stability, and we don't want that shoulder joint has to get displaced, this cavity is deepened by the presence of fibrocartilaginous rim. And what is the name of the rim? The name of the rim is glenoid labrum. Okay, so glenoid labrum is a very important factor for the stability of shoulder joint, which is attached onto the glenoid cavity periphery, and it is deepening the cavity of the shallow glenoid cavity so that the head of humerus can be accommodated inside. It can be accommodated inside. So after that, I would also like to show you the diagram, because when you see the pictures and the diagram, it becomes easy for you to understand the content. Now see here, as I told you, the head of humerus. So please see this diagram. Now what you can appreciate here, this is the head of humerus, and when you are seeing the head of humerus, this is almost a circular or sphere, not a complete, but when I will just highlight this part, so it becomes an almost circular or a spherical structure, and you can say that it has to accommodate with the glenoid cavity, which is quite shallow. Okay, so this you can appreciate, it is very rounded structure. Okay, so now moving with this, yes. So now I also want to show you the shallow glenoid surface, and you have to just, when seeing the diagram, you can understand why it is the joint which is going on for recurrent dislocation. So see here, when you see this diagram, what you are going to appreciate, that the cavity, the glenoid cavity is very shallow. This is the glenoid cavity, and when you are seeing this glenoid cavity, what you can appreciate, that this is quite shallow. This whole cavity is quite shallow. This whole cavity is quite shallow, as you can see in the diagram. Okay, this whole cavity is quite shallow as shown in the diagram, and it is pear shaped. What you can appreciate, that this cavity is pear shaped. So let me use a laser pointer. Okay, now is it okay? Now this is the glenoid cavity which is pear shaped, and this glenoid cavity is quite shallow if you compare it with the head of humerus. Here the head of humerus is rounded, and this rounded structure has to be accumulated in this shallow glenoid cavity. Okay, so this is done. Now coming to the ligaments of shoulder joint, the next topic which I want to tell you about the details is the ligaments of shoulder joint. So let me firstly enumerate the names of the ligament of shoulder joint, and then I will also tell you about the details of the ligament individual. Each ligament we will study in detail. So we are going to cover up the each ligaments in detail. So firstly, let me write the name of the important ligaments which we are going to study today. So the first in this category is fibrous capsule. The first in this category is fibrous capsule. Okay, fibrous capsule. The second is glenohumeral ligament. Glenohumeral ligament is there. Also we have got coracohumeral ligament. Coracohumeral ligament. Coracohumeral ligament, which we are going to study in detail. Also we have got transverse humeral ligament. Transverse humeral ligament. So each of this ligament, I will show you the diagram and I will give you the details of each of these ligaments. Fibrous capsule, glenohumeral ligament, the coracohumeral ligament, and that of transverse humeral ligament. Okay, now moving to the next. Other than that, we will also see the details of coracoacromial ligament. Coracoacromial ligament. And also I will show you a diagram showing the glenoid labrum. Glenoid labrum. So each of this ligament we are going to study in detail. Individual ligament, each of it we will study in detail. Now starting with the first ligament of this category, that is the fibrous capsule. Now, so in this diagram, what you are going to appreciate that okay, so in this diagram, the outermost surface, as you can see here, this part which you are seeing here is the fibrous capsule. This whole is the fibrous membrane or the capsule. So here you can see this part whole which is covering it. This whole part is the fibrous membrane or the capsule, as you can see in the diagram. This whole part, just to make you understand, this whole is covering the joint, and lower down it is getting attached. As you can see, lower down it is getting attached to anatomical neck. Okay, so yes, so this is just to make you understand. So this whole is the fibrous capsule which is covering the entire joint surface or the joint cavity surface. And one more thing I want to explain, that underlying the fibrous capsule we have got synovial membrane, and together the synovial membrane and fibrous capsule together is called as the joint capsule or the articular capsule of the shoulder joint. Also what you can appreciate that in this diagram it is exactly attached to the margins. Okay, in the lower aspect, can you see this fibrous capsule is dipping down? Can you see it is not exactly attached to the margin here, anatomical neck or the margin of glenoid fossa, but lower down it is dipping slightly. So this is the weakest point of the fibrous capsule. As we know, fibrous capsule is a very important structure providing stability of shoulder joint. The part which is the weakest point of the fibrous capsule is that of antero-inferior aspect. As you can see, it is slightly dipping down in this aspect. Okay, so the basic point is that fibrous capsule along with synovial membrane together is called as the articular capsule. Together is called as the articular capsule. Okay, together it is called as the articular capsule. Okay, now moving on to the next, that is the next slide. So I would like to give general important features of fibrous capsule of the shoulder joint. Okay, so the important features regarding shoulder joint is that it is attached. The first important point is that it is attached to the glenoid labrum. It is also important that whether it is attached inside the glenoid labrum or beyond the glenoid labrum. So the important point is that it is attached to the glenoid margins beyond the attachment of the glenoid labrum. So these are characteristic features and individual points which is very important to be memorized in relation to fibrous capsule. Okay, so it is attached to glenoid margin, but what is the location? The location is lying beyond glenoid labrum. the second point, and this is very important, has been asked as an MCQ session also. So many times it has been asked as an MCQ session that which structure is intracapsular origin in case of shoulder joint. The answer is long head of biceps brachii has got intracapsular origin in relation to fibrous capsule of shoulder joint. Okay, so long head of biceps is lying inside, its origin is lying inside the fibrous capsule. So that means if long head is intracapsular in origin, its long tendon will pass, and where the area through which it passes, that area is deficient for the tendon of biceps. Okay. Now the second point is that communicates with the subscapular bursa. The fibrous capsule also has communication with certain bursa, and the bursa from which it is forming a communication, the bursa which is having a direct communication with the fibrous capsule of shoulder joint is the subscapular bursa, subscapular bursa. And as I have shown you in the diagram, and I have told you inferiorly it is more weak. So why it is more weak, that reason is also written here, because it is descending 1 centimeter on the humeral shaft, because it is descending approximately 1 centimeters down on the humeral shaft, not exactly on the anatomical neck, but it is descending approximately 1 centimeters down to the humeral shaft. Now the next ligament which I want to explain is the glenohumeral ligament. Now glenohumeral ligament, the basic point about glenohumeral ligament which has to be memorized is that this ligament can't be visualized onto the exterior aspect. If you want to view glenohumeral ligament, what you have to see? You have to see the joint cavity from inside. Okay, so it is best visible if you open the joint cavity. Also in the cadaveric dissection, when we dissect shoulder joint in cadavers, we just open the joint cavity, and inside very nicely we can see glenohumeral ligament. And this is not a single unit. Actually glenohumeral ligament is formed of 3 parts, and the parts are called as superior, middle and inferior glenohumeral ligament. Okay, and what is the functional significance of glenohumeral ligament? The functional significance is that it is providing additional support or reinforcing the capsule. So it is also providing support to fibrous capsule of shoulder joint for the stability. Now it is also important that we should also know about the attachment of this individual ligament, that is superior glenohumeral ligament, the middle and the inferior. Okay, so let's discuss the attachment. Okay, medially, when I am talking about medially, the attachment of the supromedial margin of, means what happens, we have got 2 attachment of glenohumeral ligament, one is medially, another is laterally. So medially all the 3 parts will have the same attachment. All the 3 parts of glenohumeral ligament medially will have the same attachment. So supromedially margin, it is attached to supromedial margin of glenoid cavity, and it is fusing with the glenoid labrum. It is fusing with the glenoid labrum. Okay, supromedially attached to the margin of glenoid cavity and fuses with the glenoid labrum. It fuses with the glenoid labrum. Now moving on to the lateral attachment, that superior and medially. If we talk about lateral attachment, superior and medially, it is attached to upper and lower part of lesser tubercle. What is the attachment? It is going towards upper and lower part of lesser tubercle, and inferiorly it is going to be attached onto the anatomical neck of humerus. Okay, so first thing is medial attachment, which is similar for all the 3 parts, that is it is getting fused with the glenoid labrum. Laterally, the superior and the middle one, is attached to upper lower part of lesser tubercle, and inferior is going lower down to the anatomical neck. Okay, now coming to the diagram, which will again make you understand more nicely. Yeah, so let me try pen itself. Okay, see here. So firstly I want to show you the glenohumeral ligament superior part of glenohumeral ligament. This is the superior glenohumeral ligament, and just see here, this part which you are seeing means it is no doubt about the medial attachment. So if I am encircling this glenoid cavity and glenoid labrum, so on outer aspect this is the glenoid labrum. Okay, this is the glenoid labrum. So yes, all these ligaments are attached. So you can see superior glenohumeral ligament is also attached, merging with the glenoid labrum. Okay, and if we will see the middle glenohumeral ligament and the inferior glenohumeral ligament, it is also merging with the glenoid labrum and diverging like this. Okay, it is diverging. So inferior is going towards the neck of the humerus, and superior glenohumeral and middle glenohumeral is going towards the tubercles of the humerus. So as you can see, I am shading the three parts of glenohumeral ligament. All the three parts of the glenohumeral ligament, that is superior, middle and inferior, has been sewn inside the joint cavity, and very nicely you can appreciate that medial aspect, the attachment is towards the which structure? Medially it is attached to glenoid labrum, which is fused with the glenoid cavity. Means it is a very important ligament, providing and strengthening the stability of shoulder joint. Now thereafter I also want to give you the details of next important ligament, that is glenoid labrum. Okay, as we already know, it is a fibrocartilaginous rim. It's a fibrocartilaginous rim, and here you can see the attachment of the glenoid ligament onto the periphery of the glenoid fossa. Okay, this is the attachment on the periphery, and this is the glenoid fossa. So it is deepening the cavity of glenoid fossa. Okay, this is the, again we are seeing the joint cavity or glenoid fossa from inside to visualize the glenoid labrum. So these are the points of reference for the glenoid labrum. It's a fibrocartilaginous rim. Approximately the dimension is 4 to 6 mm. The dimension is 4 to 6 mm, and the function is deepening the cavity, protecting the joint, and also assisting in lubrication. As fusing with the glenoid labrum is fusing with that joint capsules and all, so it is also assisting in lubrication, protection and deepening the cavity Okay, so yes, so this was this mobile I am keeping for your comments and all. If any doubt you can just type here and I will see in the mobile and reply. Okay, so yes, now coming to the fourth ligament, that is coracoacromial ligament. The fourth ligament is coracoacromial ligament. Now coracoacromial ligament, which is highlighted by this which is shown in this diagram, and as you can see this coracoacromial ligament, let me just in this part yellow color, this is the coracoacromial ligament. So it is connecting two processes. This is the coracoid process of the scapula, and this is the acromial process of the scapula. So what you can say that it is giving superior support to the shoulder joint. Okay, it is giving support to the shoulder joint superiorly. With support superiorly means the shoulder joint can't be displaced superiorly. The shoulder joint can't be displaced superiorly, and acting as forming of secondary socket for the shoulder joint or secondary socket for the head of humerus. So yes, it is a triangular band which is extending from the acromial process. It is a triangular band extending from the acromial process to the lateral border of coracoid process, and the attachment is lying above the head of humerus. What is the attachment? It is lying above the head of humerus. And what is the role? It acts as a secondary socket for coracoacromial ligament. What is the function? It acts as a secondary socket for the head of humerus. So these are the important points for the coracoacromial ligament. And one more point I just want to explain here itself, that coracoid process, acromial process and coracoacromial ligament, these three structures together is called as coracoacromial arch. If we take three structures in the consideration, that is coracoid process, plus the acromial process, and also the coracoacromial ligament. If we take these three structures together is called as coracoacromial arch. Now moving to coracohumeral ligament. The next ligament is coracohumeral ligament, which is shown by the red or pink color as you can see in the diagram. Okay, coracohumeral ligament is again connecting the coracoid process. The C is coracoid process and going towards the humerus. Actually it is going towards the humerus greater tubercle. It is getting attached to the greater tubercle of the humerus, and together this structure is called as coracohumeral ligament. Coracohumeral ligament. Now let me tell you about the details of coracohumeral ligament. So, yes, Actually, it is also represented as the upper part of fibrous capsule. So in many books it is seen that it is the upper part of the fibrous capsule, and the extent of coracohumeral ligament is, it is extending from the lateral border of the root of coracoid process. Extending from root of coracoid process and getting attached to which part of the humerus? It is getting attached to the greater tubercle of the humerus, getting attached to greater tubercle of the humerus bone. This is the extent from coracoid process to greater tubercle of the humerus. Now, other important thing is that it is blending with two important structures in relation to shoulder joint. One is the fibrous capsule and the other is transverse ligament, transverse humeral ligament. Two ligaments which is merging with this coracohumeral ligament, the fibrous capsule, and transverse humeral ligament, transverse humeral ligament. Yes, now moving on, now the next ligament which I want to show you is the transverse humeral ligament. Now transverse humeral ligament is, if you will see, this is the transverse humeral ligament which is getting attached. This is the transverse humeral ligament, below which what you can see, long head of biceps tendon is moving, and this long head of biceps tendon is covered by a synovial sheath, as you can see in the diagram. This is the long head of biceps, this is the long head of biceps, and this long head of biceps is covered by a synovial sheath and is passing below transverse humeral ligament. The attachment is, it is connecting the two parts or the two lips, you can say. It is connecting the two lips of the upper part of intertubercular sulcus. Intertubercular sulcus is also called as bicipital groove. So intertubercular, if we talk about intertubercular sulcus, it is also called as bicipital groove. It is also called as bicipital groove, and the ligament which is covering this two lips of intertubercular sulcus and that of bicipital groove is called as transverse humeral ligament. The structure which is passing below it, what is the name of the structure? The structure is long head of biceps, and the long head of biceps brachii muscle origin is intracapsular. So these are the points which should be memorized if you are going to study the ligaments of shoulder joint. Now coming to the relations of shoulder joint. Relations of shoulder joint. So starting with the structures in relation of shoulder joint. So what you can see here, relations of shoulder joint. So this is the, again, the cavity which is opened up. Okay, this is the cavity which is opened up. This is the transverse cavity which you are seeing. And here you can see the important ligaments and muscles which is surrounding the shoulder joint. Important muscles and ligament which is surrounding the shoulder joint. Superiorly it has deltoid coracoacromial ligament. Superiorly it has got coracoacromial ligament, deltoid, subacromial bursas and the acromial process. Subacromial bursas and that of acromial process. These structures are lying on the superior aspect of shoulder joint. Superior aspect of shoulder joint as shown in the diagram. Now when you will see the anterior aspect, so anteriorly it is related to subscapular bursa, coracoid process, the biceps brachii, and also you can see the subscapular bursas lying coracobrachialis muscle. Means all these structures, subscapularis, all these structures are lying onto the anterior relation of shoulder joint. All these structures are lying on the anterior aspect of the shoulder joint. Now moving on to the posterior aspect, it is related with infraspinatus, glenoid labrum. It is related on, when you will see, this is on the posterior aspect, it has got deltoid and infraspinatus. Posteriorly it has got deltoid and that of inferior aspect. Okay, posteriorly it has got deltoid and that of inferior. It is related to these structures, and when we see the inferior relation, inferiorly it will have the axillary nerve which is lying here. Inferiorly it will have the relation of axillary nerve which is lying here, axillary nerve, and also posterior circumflex humeral vessel. Posterior circumflex humeral vessels and the axillary nerve lying on the inferior aspect. So one more thing you can just appreciate that this deltoid muscle which is covering the whole aspect of the shoulder joint anteriorly, also superiorly and posteriorly. So you can say deltoid muscle is covering the whole of the shoulder joint relation. It is anteriorly lying and also lying superiorly and that of posteriorly. It is lying superiorly and that of posteriorly. Okay, so these are the structures related to the shoulder joint. Now, inferiorly, axillary nerve and posterior circumflex humeral vessels. Axillary nerve and posterior circumflex humeral vessels lying on the inferior aspect. Now, coming to the relations of shoulder joint. Write down relations of the shoulder joint. So, relations of the shoulder joint are following: anterior relations. Anteriorly, write down the heading anteriorly. Anteriorly, it is related to subscapular muscles, subscapular bursa, the subscapular muscles and the subscapular bursa. Also coracobrachialis muscle is lying in anterior relation. Also the biceps brachii muscle lies in the relation. Okay, subscapular muscle, subscapular bursa, coracobrachialis and biceps brachii muscle. These structures are lying on the anterior relation of shoulder joint. Okay, subscapular bursa and also the deltoid muscle. Okay, now coming to the posterior relation. So, posterior relation is, posteriorly it is related on the posterior aspect. We have got infraspinatus muscle, teres minor, the deltoid muscle. Okay. Superiorly, when we talk about superior relation, so superiorly it is related to coracoacromial ligament, the supraspinatus muscle tendon. Also, it will also have the subacromial bursa related here, and also superiorly it will have the deltoid muscle line. Okay, so these are the relations which is lying on the superior aspect: coracoacromial ligament, supraspinatus muscle tendon, the subacromial bursa and the deltoid muscle. Indian cap, yeah, good morning dear. So today, yes, any doubt related to shoulder joint, you can just ask. I have just seen your comment. Yeah. So yes, superiorly we have done. And what about the inferior aspect? Which structures is most related inferiorly? So inferiorly it is related with axillary nerve. And posterior circumflex humeral vessels. These structures are lying onto the inferior relation. Of shoulder joint. So done. So in short, we have completed also the relations of shoulder joint. We have completed all the aspects of relations of shoulder joint. So thereafter, moving to the next. Okay, now coming to the arterial supply and nerve supply of shoulder joint. So this is the diagram in which you can see the important arteries and nerve in relation to shoulder joint, that is suprascapular artery and the nerve, which is passing through suprascapular notch and that of the spinoglenoid notch as shown in the diagram. So these supras, and also you can see axillary nerve, posterior circumflex humeral artery. So important arteries and nerve which is lying very close to shoulder joint as shown in the diagram is suprascapular artery, nerve and axillary nerve and posterior circumflex humeral artery. So in relation to this, these structures are definitely giving innervation and arterial supply to shoulder joint. Other than that, it also take arterial supply from subscapular artery. So please note down again, these points are important for the MCQ session of related to shoulder joint, the nerve supply and the arterial supply. The arterial supply of shoulder joint is anterior and posterior circumflex humeral artery. Okay. Other than that, we know that this anterior and posterior circumflex humeral artery and also the subscapular artery, these are the branches of third part of axillary artery, and suprascapular artery which will be a branch of subclavian artery. So subclavian artery, which branch? Thyrocervical trunk. If we talk about subclavian artery, it's one of the artery is thyrocervical trunk, and suprascapular artery is a branch of thyrocervical trunk of the subclavian artery. Subscapular artery is a branch of third part of axillary artery, and also anterior posterior circumflex humeral artery is a branch of third part of axillary artery. The nerves: musculocutaneous nerve, suprascapular nerve, and axillary nerve. Now here axillary nerve is a branch of posterior cord of brachial plexus. Suprascapular nerve is a branch of trunk of brachial plexus, upper trunk of brachial plexus. And musculocutaneous nerve is a branch of lateral cord of brachial plexus. It is a branch of lateral cord of brachial plexus. So these are the details of nerve supply and arterial supply in relation to the shoulder joint. So you have to also correlate the branch. So I have written all the branch's name. Yeah, now moving to the next. So with this we have finished till now what? We have finished the arterial supply, we have finished the nerve supply, you have also finished the relations in of the shoulder joint, and we have also finished the ligaments. Now what is important is the movements. Movements of shoulder joint is very important, and MCQ is framed from this topic. So all the muscles which is performing various movement, once again as we know that it is a ball and socket type of synovial joint. That means the degree of movement of freedom is more than 2, that is 3 degree of freedom of movement. So at this joint flexion extension is possible. Okay, that is extension mein kya hota hai? Angle between the joint is increased, flexion is there, angle between the joint is decreased, abduction and adduction moving away and towards the body, and we have got medial rotation and that of lateral rotation. So all has been done, and combination movement of these movements is called as circumduction. So yes, we are if we move like this, this is flexion. If we move posteriorly, it is extension. So the diagram has been given you to relate the movement of shoulder joint, and it is important that the individual muscles which is performing these movements should be well known to you, and you should be having the proper knowledge of this, because MCQ is so many MCQs comes from this topic. Yeah. So now starting with the first movement, that is the adduction of shoulder joint. So see here, both adduction and abduction movement has been shown in this diagram. Adduction, abduction. What is abduction? Moving away from the body. It's moving. Abduction means the shoulder joint is moving, arm is moving away from the body, and adduction means the arm is moving towards the body, as you can see. Now let me tell you about the name of the muscles which is performing this movement. So prime movers of adductors are, prime adductors of shoulder joints are pectoralis major and latissimus dorsi. Okay, prime movers are pectoralis major and latissimus dorsi. Okay, to be more specific, sternocostal fibers of the pectoralis major causes adduction movement. Flexion movement is caused by clavicular part. So which fibers of pectoralis major muscle is causing adduction? Sternocostal fibers. Sternocostal fibers. So sternocostal fibers are performing the action, that is adduction of shoulder joint, and the latissimus dorsi. The other muscles which is also assisting this movement, the muscles which is also assisting this movement is coracobrachialis and biceps short head. Coracobrachialis and biceps short head. Now moving to the other movement, that is the abduction movement. Again we are seeing that abduction means moving away from the body. The prime movers are middle fibers of deltoid. Middle fibers of deltoid is also called as acromial fibers of deltoid. Okay, this has been asked in so many times in the MCQ, and the major degrees of abduction performed is from 15 degree to 90 degrees of abduction. Now the process of initiation of abduction is done by which muscle? Supraspinatus muscle, which performs 0 to 15 degrees of abduction. It performs 0 to 15 degrees of abduction. 0 to 15 degrees of abduction. Overhead abduction means the abduction movement above 90 degrees. Actually total abduction is done how many degrees? 180 degrees. Okay, so overhead abduction, like if we comb our hairs and we are moving our arm above 90 degree, that is done by the serratus anterior muscle along with the trapezius fibers muscle. So two muscles is causing overhead abduction, that is now greater than 90 degree. that means greater than 90-degree abduction, and the muscle taking part in this movement is serratus anterior and that of trapezius muscle. Serratus anterior and that of trapezius muscle. Now, this is a diagram in which, this is a diagram taken from Langman's from last anatomy, and here what you can appreciate that how the whole of 180 degree of abduction is achieved. Now see here, where the this is the diagram in which you are seeing shoulder joint. The arm is lying by the side of the shoulder, but here what you can see, it's very easy, means just now we can just move about 90 degree. This is that 90 degree. When the 90 degree of abduction is achieved, can you see no space is lying here, no articular space is left. What this can be appreciated in the diagram, that no articular space is left there for further abduction. So to move the shoulder joint further to this movement, what is required? Lateral rotation is required. So after 90 degree of abduction, the humerus is laterally rotated. It is laterally rotated, and again space is formed and the further abduction can be done. But after that, again there is no space, and after lateral rotation of arm, the next movement which takes place is the scapula is moved forward. Scapula moves forward. So when the scapula moves forward, the full 180 degrees of abduction is possible. So in the fourth diagram, you can see the full 180 degrees of abduction is possible, and the reason of full 180 degrees of abduction being possible is by the movement of the scapula forward. So till 90 degree, no space is left for further movement. Further movement requires lateral rotation of the arm or humerus. Thereafter, we can achieve further movements of 120 degree. Again, after that, there is no further space left for the further abduction movement. And for further abduction movement, the scapula moves forward, and this will lead to the achievement of full 180 degrees of abduction. Now coming to the flexion and extension of shoulder joint. The prime muscles which is performing the flexion movement, as I told you, is the clavicular head of pectoralis major and the anterior fibers of deltoid. The other name of anterior fibers of deltoid is, it is called as clavicular fibers of deltoid. Okay, clavicular fibers of deltoid. So in flexion, the arm is moved in front, forward, and when the arm is moved, shoulder is moved more backward, it is called as extension. And the movement of flexion is assisted by other muscle, that is coracobrachialis and biceps brachii muscle. Coracobrachialis and biceps brachii muscle. Extension of shoulder joint. Okay, when we want to know which muscle is causing extension, it is caused by two important muscles. One is the posterior fibers of deltoid, another is the latissimus dorsi. Posterior fibers of deltoid is also called as spinous fibers of deltoid. The other name is, it is also called as spinous fibers of deltoid. These two muscles perform the extension movement of shoulder joint. Spinous process of deltoid and latissimus dorsi. Now coming to medial rotation of shoulder joint. Medial rotation. Medial rotation of shoulder joint is done by pectoralis major. Again, which fibers of pectoralis major? Sternocostal fibers. Sternocostal fibers. The sternocostal fibers are performing the function of medial rotation of shoulder joint. Anterior fibers of deltoid muscle is also performing medial rotation of shoulder joint. The subscapularis muscle and that of teres major muscle. The subscapularis and that of teres major muscle. All these muscles together performs medial rotation of shoulder joint. Pectoralis major, anterior fibers of deltoid, subscapularis and teres major muscle. Okay? Subscapularis and teres major muscle. Coming to the next, that is lateral rotation. Lateral rotation is done by deltoid posterior fibers, infraspinatus and teres minor muscle. Three muscles, deltoid posterior fibers, again that is spinous fibers, infraspinatus and that of teres minor. So deltoid posterior fibers is called as spinous fibers. So it is important that you should memorize all the muscle which is causing these movement, name of the muscle, that is very important to be memorized. Now thereafter I want to show few X-rays by which you can appreciate the clinical correlations of shoulder joint, anterior dislocation, posterior dislocation and inferior dislocation. And we know that most common dislocation in case of shoulder joint is the anterior dislocation. So see here, the head of humerus has moved down here. below the coracoid process also, as you can see. So this diagram here, you can appreciate which dislocation, anterior dislocation of shoulder joint. And when there is anterior dislocation of shoulder joint, and as the head of the humerus is coming in more inferior position, okay, so at that time there can be injury of axillary nerve, and when the axillary nerve is injured, what will happen? The rounded contour of the shoulder joint is gone, okay, because of the paralysis of which muscle? That is the deltoid muscle, because deltoid muscle is getting innervation from which nerve? Axillary nerve, and due to anterior dislocation of shoulder joint, axillary nerve is injured. Now, so what I told you, most common, that 95% of all the shoulder joint is of which variety? Anterior dislocation. And in most of the cases, the head of the humerus come to rest under the coracoid process, and this is called as subcoracoid dislocation. This is called as which type of dislocation? Subcoracoid dislocation. This is called as subcoracoid dislocation. Okay, shoulder joint dislocation, that is anterior dislocation, in which this head of humerus is coming to rest below coracoid process, is a subcoracoid dislocation. Now, other points of dislocation or other stages or the level of dislocation is subglenoid, subclavicular. This is subglenoid, subclavicular, and rarely it can be intrathoracic or retroperitoneal dislocation. The major locations are subglenoid, subclavicular, and it can also be retroperitoneal or intrathoracic dislocations. Okay, so these are various levels of dislocation and the positions of dislocation of anterior variety, anterior dislocation. Now, this is another diagram in which again you can see this is the head of the humerus which is anteriorly displaced. It is anteriorly displaced, or you can say dislocated, as shown by the arrow. It is just going inferior to its location, as shown by the blue and the red arrows. And what will happen? It will lead to, actually, if you talk about the mode of injury, the mode of injury is falling. Either there can be a direct blow on the shoulder joint, or you fall on outstretched arm. You fall on the ground or you fall on the floor by an outstretched arm. This can be the mode of mechanism of anterior dislocation. And when the person comes to the OPD, he or she will particularly hold his or her arm in which position? Anterior dislocation, the position of the arm when he or she comes to the clinics will be externally rotated and slightly abducted. So this is very important again for MCQ, that what is the position when, so he or she holds the arm and come to the clinic is positive. For it's the important sign both for anterior and posterior dislocation. But what is important is to differentiate the position of the arm. So in anterior dislocation, it is extended and slightly abducted. It will be extended and slightly abducted. This is the difference from the posterior dislocation position. In posterior dislocation, it will be internally rotated and slightly adducted. Internally rotated and slightly adducted. Now, anterior dislocation is of two varieties. One is Hill-Schack and other is Bankart. Two varieties. One is Hill-Schack and other is Bankart lesion. Okay. Now, I want to tell you about the difference between two and I will also show you an X-ray so that you can differentiate between two types of lesion. So, in case of Hill-Schack lesion, there is impaction of the head of humerus by glenoid rim during the dislocation. So, head of humerus is impacted. It is impacted left by glenoid rim during dislocation, and in if we talk about its percentage where it is present, so it is present in 35 to 40% of cases of anterior dislocation. It is present in 35 to 40% cases of anterior dislocation, and it can be visualized once we see the front facing X-ray and when the arm is in internal rotation. In Bankart lesion, what will happen? The glenoid labrum is disrupted. There is injury or tear of glenoid labrum, which was not seen in case of Hill-Schack. But in Bankart, clearly you can see the disruption of glenoid labrum, which will have a part or avulsed part of the bone fragment, or sometimes without the bone fragment. So this is the difference between Hill-Schack and that of Bankart and that of Hill-Schack dislocation. So let me show you the diagram for this. So see here this is an here you can see this is the head of the humerus. Here the impaction has been shown. So in Hill-Schack reason, what happens, there is impaction of the glenoid labrum, and in Bankart lesion what happened, disruption is there, and also you can see this is the bone fragment avulsed. Okay, so this is Bankart. So to just see the diagram and the x-ray, superiorly you can visualize the Hill-Stack lesion. Okay, and inferiorly is the Bankart. In Bankart there is glenoid disruption and avulsion fragment of the bone. In Hill-Stack there is impaction of the head of humerus, as you can see. Okay, so these are two varieties of anteriorly dislocated shoulder joint. Now as in the beginning only I told you that axillary nerve is injured in anterior dislocation of shoulder joint. Here we can see the injury of axillary nerve as shown. And when axillary nerve is injured, what will happen? The deltoid muscle is paralyzed, and when deltoid muscle is paralyzed, which movement is affected? Abduction movement is affected. So which movement will be affected when axillary nerve is injured? Abduction movement is affected, and there is loss of shoulder contour. There is loss of shoulder contour. There is loss of shoulder contour. Now coming to the posterior dislocation. Next type of dislocation which is quite common is posterior dislocation, and please see the x-ray. Can you see this is the outline of the head of humerus, and it appears like a bulb is shining, a bulb is on. So light bulb sign is the x-ray or radiological feature which is seen in posteriorly dislocated shoulder joint. Can you see here? This sign is light bulb sign. So light bulb sign is seen in cases of posteriorly dislocated shoulder joint, and on left hand side what you can see here, this is reduced. This is after the treatment and it is reduced. Okay. Now coming to the mode of injury. The mode of injury is due to any kind of greater force of muscular contraction, electric shocks and seizures. Okay. In case of anterior dislocation, the fall was on outstretched hand on the floor. Here the mode of injury is electric shock or seizures. And the people with dislocated shoulder joint, as I told you, just the reverse of anterior dislocation. When they reaches the clinics, when the posteriorly dislocated patients come to the clinic, they will hold their arm by holding the arm in internally rotated position and adducted position. Okay, and there will be also flattening of anterior shoulder with the prominence of the coracoid process. There will be prominence of coracoid process. Now coming to the other type of dislocation, that is inferior dislocation. Inferior dislocation. The mode of injury is a high grade of injury, for example automobile accidents. It is very rare. One of the thing is that this kind of injury, as you can see, inferiorly dislocated, this kind of injury is very rare condition, and a high grade injury of automobile accident, very forcefully if the head of humerus is inferiorly dislocated, and you can see the humerus is in abducted position, and there is fracture also of the greater tuberosity. There is fracture of the greater tuberosity. It can present with the fracture of greater tuberosity because it is more dislocated going on the inferior aspect. So one more thing, that what is a particular name? There is a particular name given to this rare kind of dislocation, that is inferior dislocation, and the name is luxatico erratica. What is the name? The name is luxatico erratica, in which the arm appears to be permanently held upwards and behind. The arms helps to be permanently held upwards and behind the head. It is caused by hyper-abducted position of the arm that forces the humeral head against the acromial process. It is caused by hyperabduction of the arm that forces the humeral head against the acromial process. Okay. Inferior dislocation occurring in less than 1% of the individuals. So yes, in short, I would also like to tell you about the bursas related. So 4 bursas are related: subscapular, subacromial, infraspinatus and subcoracoid. 4 important bursas: subscapular, subacromial, infraspinatus and subcoracoid. So see here, subacromial process below the acromial process, subcoracoid process below the coracoid process, and subscapular process will be lying anteriorly below the subscapular muscle. So here in this diagram, the subscapular bursa is shown, and as you can see, this is the location of subscapular bursa. And as in the initial part of when we were discussing it also, the fibrous capsule, I told you that subscapular bursa is the bursa which is forming communication with the joint cavity. So you can see it is the joint cavity inside, and this subscapular bursa is forming communication inside the joint cavity. Now coming to the so one more thing which I want to show you here is the location of subacromial bursa. So see here, this is the acromial process of the scapula, this is the coracoid process of the scapula, and the exact location of subacromial bursa or space is lying between supraspinatus muscle. So it is sandwiched between acromial process, coracoacromial ligament, and that of the muscle tendon. Which muscle tendon? Supraspinatus muscle tendon. So exact location of subacromial bursa. You can also say it is lying below the deltoid, so it is also called a subdeltoid bursa, one of the large bursa of the body, and it is sandwiched between ligament, that is coracoacromial ligament, and supraspinatus muscle. This is the reason that it can impinge the supraspinatus muscle tendon. So yes, as I told you, subacromial bursa is also called a subdeltoid bursa, one of the largest bursa of the body, and one of the key point is that this bursa is not communicating with the joint cavity. This bursa is not communicating with the joint cavity. Now we have got infraspinatus bursa. So infraspinatus, this small bursa which you are seeing here, actually the location is posterolaterally to the joint cavity. The location is posterolaterally to the joint cavity, as you can see in the diagram. Subcoracoid bursa is small bursa lying below the coracoid process. Stability. So yes, we have completed the topic, just finishing it with just revising the stability. So we have already discussed glenoid labrum, coracoacromial ligament, and long head of biceps tendon is forming stability. Along with it, rotator cuff muscle is also forming stability for shoulder joint. Okay, so glenoid labrum, we have already seen it is deepening the cavity of glenoid fossa and increasing the stability of shoulder joint. And now see here, this is the coracoid process. As you can see, this is the coracoid process, this is the acromial process, and it is connected by a ligament, that is coracoacromial ligament, and as I told you, it is together called as coracoacromial arch, which is preventing superior displacement of shoulder joint. Now we can see a 4 muscle tendon, that is sits. Altogether it is called as sits, and this is just holding together the head of humerus towards the medial aspect of glenoid cavity. What is the role? It is holding together the head of humerus towards the medial aspect of glenoid cavity, and the muscles are supraspinatus, infraspinatus, teres minor, and that of the subscapularis muscle. Rotator cuff, out of the 7 scapulohumeral muscle, most important is these 4 rotator cuff muscle. Long head of biceps brachii muscle is also intracapsular, and it prevents the upper displacement of the shoulder joint. Now painful arch syndrome. Now when I have shown you a diagram in which you have seen supraspinatus muscle tendon is can be lying below, and also there is subacromial bursa lying above, and coracoid and acromial process is also lying above. So there can be chance in cases of inflamed subacromial bursitis that there can be the chance of supraspinatus muscle being impinged, and this can lead to painful arch syndrome, and the range of pain is approximately from 45 to 160 degree of abduction. In the initiation and extreme movements, as you can see in the initiation, so in the initial and extreme movements, there is not much of compression of the supraspinatus muscle, or there is a space, but in the middle range of movement, the supraspinatus muscle is compressed. So this is more painful. Now painful arch syndrome 1, 2, 3, 4 and 5, these are the reasons of painful arch syndrome. It can be from following reasons. It can be either due to minor tear of the supraspinatus muscle, supraspinatus tendinitis, inflammation, calcific deposit in the tendons of supraspinatus muscle, subacromial bursa, or injury of the greater tuberosity of the humerus. So these are 5 reasons of the causes of painful arch syndrome has been highlighted here. Now frozen shoulder, this is commonly seen in middle-aged women more. There is a restriction of all the movements, but there is no X-ray findings. When we will take the X-ray findings, there is no X-ray findings visualized, and the other name which is used for frozen shoulder is adhesive capsulitis. What we call it? We call it as adhesive capsulitis, and there is restriction to the and limitation to all movements of the shoulder joint. And one of the basic point is that spontaneous recovery is seen in these cases, and we can advise the patient for physiotherapy, and in very painful conditions, steroid injections can also be given to the patient. Now, the reasons or pathological causes, can you see this is a very healthy fibrous capsule and this is the adhesive fibrous capsule which is causing frozen shoulder. Formation of adhesion is the cause. Also, the flexibility of joint capsule is lost, and this can, other reasons can be inflammation of the capsules and rotator cuff, involvement of subacromial bursitis or deltoid muscle involved. This can be the reason, but the good point is that no X-ray findings has been found, but pain is rare. But with exercise and with lifestyle modification, it can be released, it can be relieved in few months. Now, osteoarthritis of shoulder joint. Actually, osteoarthritis in case of shoulder joint is less common. Okay, osteoarthritis more common in which joint? It is more common in hip joint and knee joint. But at certain condition, we can also see osteoarthritis, and generally the case has got a history of injury, avascular necrosis of the head. There is restriction to the movements, and in when you will see the X-ray of osteoarthritic patient, there will be reduced space of the joint cavity. Articular cartilage atrophies and there is reduced joint space, and there is formation of new bone fragments that is called as osteophytes. See here you can appreciate this is the X-ray of osteoarthritic patient. The joint space is reduced, as you can see, and also you can see lower down this is the formation of osteophytes. So these are the findings suggestive of osteoarthritis. Now, before ending the session, I would like to tell you that you can use my referral code Dr. Lisa -YT, Dr. Lisa -YT for 10% discount. You can join the Telegram group, that is Unacademy NEET PG. Unacademy NEET PG. So do join this group, Unacademy NEET PG. This is the Telegram group of Unacademy platform. You can have the session, live sessions of all 19 subject can be visualized, and you can find the goal. You can download the app and you can find the goal, that is NEET PG, and you can follow any of your educators from the list. And also you can find me on the Unacademy platform as an anatomy faculty, and you can also search for me on a Telegram group link, that is Monalisa Anatomy. My own Telegram group link is Monalisa Anatomy. So you can join this Telegram group link. In this group, I am sharing all my upcoming free live session, also the PDFs of the previous session, also the link of seeing all the previous session. Also, if those who wish to see the MCQ session, so they can see my previous MCQ sessions also. All the best, keep studying. Thank you so much. All the best. Thank you. So, thank you so much. Thank you.